Welcome to this session on palliative care in the ICU. Today, we'll talk about what palliative care really means, why it matters in critical care, and how ICU nurses play a key role in supporting patients and families through serious illness. In today's session, we have 5 main goals. First, to understand what palliative care is and the philosophy behind it. Second, to clarify the difference between palliative care, end-of-life care, and hospice. Third, to review the key principles of palliative care in an ICU setting. Fourth, to highlight the essential role of nurses in assessment, communication, and symptom management. And finally, to recognize common symptoms and the appropriate nursing interventions. So what exactly is palliative care? According to the WHO, palliative care is an approach that focuses on improving the quality of life for patients and their families facing serious illness. It looks at the whole person, not just the disease, including physical, psychological, social, and spiritual needs. Palliative care is not the same as hospice. Hospice care is for patients in the final months of life, when treatment is no longer curative. Palliative care, on the other hand, can start at any stage of a serious illness. Patients can still receive active treatment, and the goal is to improve comfort and quality of life. Both use a team approach, but palliative care begins much earlier. Palliative care should not be reserved only for the final days of life. In the ICU, it should begin early, together with treatments like ventilation or vasopressors. Early integration helps manage symptoms from the start, improves communication with families, and ensures that treatments match the patient's values. It also reduces stress for both families and the healthcare team. The integrated model of palliative care means we don't wait until the very end. Palliative care should start as soon as a serious illness is diagnosed and continue throughout treatment, the end of life, and even into family bereavement. It works alongside curative treatments like surgery, chemotherapy, or ICU care. As the illness progresses, the focus gradually shifts from curing the disease to maximizing comfort and quality of life. Palliative care can be provided across all healthcare settings, hospitals, ICU, clinics, and even at home. The key idea is that palliative care follows the patient, not the location. Why do we need palliative care in the ICU? ICU patients often have rapidly worsening conditions and severe symptoms like pain, shortness of breath, or anxiety that are hard to control. Both patients and families experience high levels of psychological stress. Palliative care helps us make sure high-tech ICU treatments truly match the patient's values and what they want for their life and care. The goal of palliative care is simple: to prevent and relieve suffering, and to improve the quality of life for both patients and their families. Its core principles include affirming life while recognizing death as a natural process. Palliative care does not try to speed up death or delay it. It treats the patient and family as one unit of care and relies on an interdisciplinary team working together. In the ICU, nurses play a central role in palliative care because we are present 24 hours a day. We are often the first to notice pain, discomfort, or emotional distress. Our key responsibilities include assessing symptoms, managing them with both medications and non-drug methods, and communicating clearly with patients and families. We advocate for the patient's wishes, support decision-making, and provide psychosocial and spiritual care. And finally, we guide families through end-of-life care and post-mortem support when needed. To deliver quality palliative care, we look at the whole person, not just the disease. This framework includes many domains: physical symptoms, psychological and social needs, spiritual and cultural considerations, and the care of patients who are near the end of life. It also covers how care is organized and the ethical and legal aspects involved. Together, these domains remind us that palliative care is truly holistic. The concept of total pain reminds us that suffering is not only physical. When a patient says they hurt, it may include psychological, social, or even spiritual pain. As ICU nurses, we must assess all of these components, not just the physical symptoms, because each one affects the patient's overall experience of suffering. Symptom assessment is a core competency in palliative care. Pain is considered the 5th vital sign, so we must assess it regularly. For patients who can communicate, we can use tools like the ESAS scale. For nonverbal patients, tools such as CPOT or BPS help us evaluate pain through behavior. We also use the RASS scale to assess agitation or sedation. When assessing pain, remember WILDA. The words they use, intensity, location, duration, and what makes the pain better or worse. This is the Edmonton Symptom Assessment System. It's a self-report tool that helps patients rate different symptoms, such as pain, tiredness, appetite, nausea, depression, anxiety, and shortness of breath, on a scale from 0 to 10. It gives us a quick overview of how the patient is feeling right now. This is the Critical Care Pain Observation Tool. It's used for patients who cannot communicate their pain. The tool looks at 4 areas: facial expression, body movements, muscle tension, and either ventilator compliance or vocalization. By scoring these behaviors, we can estimate the patient's pain level and adjust our interventions accordingly. This is the Richmond Agitation Sedation Scale. It helps us assess a patient's level of agitation or sedation, ranging from +4, which means combative, down to -5, which means unresponsive. A score of 0 indicates the patient is alert and calm. RASS guides us in adjusting sedation, ensuring the patient is neither overly agitated nor overly sedated. This is the Pain Assessment Scale, ranging from 0 to 10. 0 means no pain, and 10 represents the worst pain imaginable. Using this scale helps patients describe their pain clearly, so we can adjust treatment appropriately. For pain management, we often follow the WHO 3-step analgesic ladder. Mild pain starts with non-opioids like acetaminophen or NSAIDs. Moderate pain uses mild opioids, such as codeine or tramadol. Severe pain requires strong opioids like morphine, fentanyl, or hydromorphone. As nurses, our responsibilities include giving medications around the clock, providing PRN doses for breakthrough pain, advocating for proper pain relief, and monitoring side effects such as constipation, nausea, and sedation. Dyspnea, or shortness of breath, is one of the most frightening symptoms for patients. We manage it using both non-pharmacologic and pharmacologic approaches. First, non-drug methods. Elevate the head of the bed, use the tripod position, create a cool airflow with a fan, and provide reassurance to reduce anxiety. For medications, morphine is the gold standard for relieving air hunger. We also maintain oxygen saturation above 90%, and if the patient is in fluid overload, we may limit IV fluids or give diuretics. Together, these interventions help the patient breathe more comfortably. Nausea and vomiting are common symptoms in seriously ill patients. We first look for the cause, such as opioids, constipation, or anxiety, and treat it. Antiemetics should be given regularly, and frequent oral care helps keep patients comfortable. Constipation is also very common, especially when opioids are used. Prevention is essential, so we start a bowel regimen early with both a stimulant and a stool softener. If possible, encourage light physical activity and adequate fluid intake. Terminal delirium and agitation are common in the last days or hours of life, and they can be very distressing for families. When this happens, we always check for reversible causes. Is the patient in pain that hasn't been treated well? Is there urinary retention? Do we need to check the Foley or bladder? Could constipation or impaction be contributing? Or are there medication side effects? Identifying and treating these factors can reduce suffering and bring comfort to both the patient and their family. For pharmacologic management of delirium and agitation, haloperidol is the first-line medication when the cause is not reversible. Benzodiazepines, such as midazolam or diazepam, can actually worsen delirium unless they are specifically being used for anxiety, seizures, or for palliative sedation. Palliative sedation is a carefully monitored use of medication to relieve severe, refractory symptoms. It is an ethical and compassionate option when a patient is suffering deeply. Comfort care is not only about medications. Non-pharmacological measures are just as important. Physically, we provide good oral hygiene, especially for NPO or intubated patients, along with personal care such as bed baths, eye care, and back care. We also manage wounds and pressure sores through repositioning and proper dressings, and we take care of tracheostomy sites with suctioning and cleaning. Environment and psychological comfort matter too, using relaxation or breathing exercises, and controlling light and noise levels to help the patient feel calm and safe. Communication is a core skill in palliative care nursing. It begins with skilled listening, paying close attention not only to words, but also to emotions. We need to be able to respond to difficult questions about life and death, and sometimes the best response is silence, presence, or a gentle therapeutic touch. We also have to discuss sensitive topics, like imminent death, with families in a compassionate and honest way. Honesty and openness help patients and families feel safe to express their fears and concerns. The SPIKES model is a 6-step framework for having difficult conversations, such as breaking bad news. First, setting. Choose a private, calm space and sit down with the family. Second, perception. Ask what they understand about the patient's condition. Third, invitation. Ask how much detail they want to know. Fourth, knowledge. Share information slowly and clearly, without medical jargon. Fifth, empathy. Acknowledge emotions and respond with compassion. And finally, summary and strategy. Recap what was discussed and outline the next steps. This structure helps families feel supported, even during very hard conversations. Supporting the family is a key part of palliative care. We start by understanding their structure, strengths, and what information they may be missing. Encouraging open communication among family members helps reduce confusion and stress. We also involve them in the patient's care whenever appropriate. Even simple tasks like oral care or repositioning can help them feel connected and useful. Most importantly, we respect their privacy and accept that every family copes in different ways. When providing palliative care, cultural and religious sensitivity is essential. In many communities, decisions are made not by one person but by the entire family or by respected elders. In Islamic ethics, the sanctity of life is extremely important, and euthanasia is not permitted. Palliative care aligns well with Islamic values because its goal is to relieve suffering, not to hasten death. We should allow time and space for prayer, such as salah or dua, and understand that spiritual support from a sheikh or imam can be very meaningful for families during difficult moments. Moving to ethical and legal considerations, we prioritize shared decision-making over the old doctor decides model. This means the medical team and family work as partners to make decisions together. We also use advanced care planning to discuss future wishes, but note that in the Somaliland context, this is rarely a formal document. Instead, you should treat it as an ongoing conversation with the family to understand the patient's values. This dialogue is essential to establishing the right goals of care. We address the sensitive ethical concept of do not resuscitate, or DNR. When teaching this in Somaliland, we must be careful to distinguish between global definitions and our local reality. Globally, a DNR is a formal medical order, written by a doctor after discussion with the patient or family. It specifically states that CPR will not be performed if the heart stops. This is done to respect a patient's wish to avoid high-burden, often futile interventions. The goal is not to abandon the patient, but to avoid inflicting unnecessary suffering at the end of life. In the specific context of Somaliland, we do not currently have a formal, standardized DNR policy in our national health regulations. Instead, these sensitive decisions are handled on a case-by-case basis. We rely on close family consultation and clinical judgment, while deeply respecting Islamic and community values. The focus is purely on not inflicting harm and allowing a natural death when treatment is futile. Our goal is to understand this principle, avoiding burdensome care, and apply it through compassionate family communication. We must also attend to the patient's psychosocial and spiritual needs. Psychosocially, encourage patients to verbalize their fears and provide the family with accurate, timely updates on the prognosis. Spiritually, remember that this is a highly personal domain. We must respect the patient's religious beliefs, even if they seem to interfere with medical treatment. Always assess their desire for support and involve spiritual leaders, like sheikhs or imams, whenever requested by the family. Finally, when providing care at the end of life, our goals are to provide comfort and ensure a dignified death. This is sacred work, where the nurse enters the patient's intimate space to facilitate life closure. We shift our focus entirely to comfort by discontinuing non-essential monitoring, labs, and medications. Instead, your priority becomes managing terminal symptoms like secretions, pain, and restlessness. Crucially, we must support the family's presence, ensuring they can be with their loved one in these final moments. Palliative care is fundamentally teamwork, meaning you are never alone in managing the patient's care. We rely on a broad interdisciplinary team to support the whole person. This includes doctors and nurses, but importantly extends to pharmacists, social workers, and paramedical aides. Crucially, we involve chaplains or spiritual practitioners to address spiritual needs, alongside volunteers and counselors. Each member brings unique expertise, ensuring the patient and family are supported from every angle. Let's address some common myths that act as barriers to care in the ICU. First, palliative care is not restricted to the dying. It can be integrated at any stage alongside curative treatments. Second, accepting palliative care does not mean giving up hope. Rather, it shifts our hope toward a life with minimal suffering and maximum dignity. Finally, palliative care is not limited to cancer patients. It is vital for anyone with a serious illness, including heart failure, COPD, or renal disease. In summary, remember that nurses play a central, irreplaceable role in palliative care. Your skills in communication and nursing are essential to delivering optimal care and improving quality of life. Please remember that palliative care is never about giving up. It is simply a shift in focus. It is about helping patients live through their illness with dignity. Our ultimate goal is to add life to days, not just days to life. You are now empowered to provide this compassionate, holistic care in your ICU. Thank you for your attention. I hope this session helps you feel more confident in providing compassionate palliative care in the ICU.